coming back. Yeah, there you go.
All right, we'll just give it like a couple minutes for people to join, and then we can begin.
All right. Hmm. So you guys kind of have different people from like different fields come on and like talk about their fields and stuff. Is that kind of the goal, and like get a little shadowing experience too, something like
Yeah.
that?
Yeah, so basically since like COVID hit, it's hard to like get shadowing like time to like shadow doctors and stuff because like a lot of doctors aren't allowing students to come and see them, especially due to like, the pandemic and stuff. So we tried to find making a virtual shadowing experience for those students who still want to get their shadowing hours and still learn about other like all types of like fields of medicine. And so we thought like doing a YouTube live type of format would be like the most effective way to do that. So we just get a couple doctors every week to like come and speak about, what they do some case studies and stuff like that.
Good. Yeah, that's really good. You guys are, doing a good job, and
Thank you.
keep it up. Yeah.
But yeah, thank you so much for doing this today. Like radiology is also like a really interesting field. So
Yeah, that's
working
kind of
on
what I want to pursue eventually, somewhere around this.
Really? Okay. Good, good. Yeah, I hope that this kind of you know, I guess pulls back the curtain a little bit, if you will. Like I feel like nobody really knows what radiology does really.
right.
You know?
Yeah.
Um and it's there's kind of like a wide variety of things that you can do within radiology too. So that's probably also why people are confused, or I don't want to say confused, but maybe they just don't know as much
Mhm.
about kind of what we do in radiology.
Wait,
Yeah.
so how similar would you say radiology is to like radiation oncology?
There is some overlap, more so with like interventional radiology and radiation oncology. Radiation oncology is more, it's basically focused on just cancer and cancer treatments,
Mhm.
obviously using radiation. We have a lot of overlap with them in the sense that interventional radiology also does a lot with cancer in terms of treating and biopsying and everything like that. And, diagnostic radiology is really important because, when you're looking for a cancer, you got to get imaging, right? You got to get, either a CAT scan or MRI. So that's where, diagnostic radiology comes in, because diagnostic radiologists, they look at the CAT scan, they look at the MRI, and they say, oh, there's a mass in the liver, or whatever it is. Um, and then actually we have interdisciplinary conferences. So we have tumor boards where basically there'll be a radiologist, the oncologist, and a radiation oncologist. And sometimes the surgeons are there too, where we'll kind of discuss the different cases. And, like the oncologist will usually present the case and be like, oh, this is a, 55-year-old male with blah, 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 right? And then, we'll show the imaging, and then everyone will kind of have their input as to, what it could possibly be and what kind of the best treatments would be. So we work very, very closely with radiation oncology. Yeah.
Okay, yeah, that's really cool.
Alrighty, so we have about 14 people right now on Zoom. So I'm going to introduce you and you can get started right after that, all right?
Perfect.
Alrighty. Hello, everybody. Thank you for attending today's My Medical Message shadowing session. Today I have Dr. Asad Baig. He is a chief resident of radiology, and we're super excited to have you here to speak about your experiences and tell us more about radiology.
Of course. First off, thank you guys for having me on. And, if you're not following My Medical Message and if you're not kind of involved with them, they're doing a pretty good job of getting all different kinds of people on in terms of different physicians and everything like that. So, make sure that, you're following them. So I kind of wanted to gear this talk a little bit of, kind of going into what exactly is radiology, what is interventional radiology, and then we can kind of go into a case. And if you guys have any questions along the way, you have your wonderful hosts here, they're going to be on and taking your questions and sending them to me, and then we'll we'll answer them as we go along. Okay. All right. All right. So I want to go to the next slide, but
If you just click, it'll go.
Okay, so now let me go back. Presentation mode. Okay, so all right, so a lot of people are not even sure exactly what radiology is. So I kind of just put it in a simple definition, and I think this may have been from Wikipedia, to be honest. Don't quote me on this, but it's the medical discipline that uses medical imaging to diagnose and treat diseases within the bodies of animals, including humans. Basically, it's a fancy way of saying, we are doctors who basically have gone through medical school, but when we do our residency, we do a year of either internal medicine or surgery, and in the next 4 years, we spend basically looking at different types of imaging modalities. So, for example, X-rays, CAT scans, MRIs, nuclear medicine studies, ultrasound. So pretty much any kind of imaging that could lead to a diagnosis, mammograms as well. We have to learn not only the disease processes behind what it looks like, but we have to know, all right, we learned anatomy in 3D by, looking at cadavers and everything, but now we have to kind of look at it on the screen and we kind of have to diagnose things that way. All right, so it's a lot of like kind of putting puzzle pieces together and kind of like figuring out like what's wrong with the patient, looking at the clinical history and then also looking at imaging. All right, and these are a couple of images that you might have associated with radiology. You can see this radiologist, looking at this is a CT scan or a CAT scan. And then, right here, this is basically, CT scanner. And, that's what these things look like. Okay. All right. All right. So, I mentioned a few of these things earlier. What imaging is included within radiology. So pretty much kind of any imaging modality that you can think of. You've got over here, you've got X-rays. This is another X-ray of the skull. This is what we call a lateral view. Basically, it's as if you turn your head and the X-ray beam goes, this way. Okay. This is also an X-ray here. Right here is an MRI of the brain. I know it looks kind of weird, right? But it's pretty high resolution. So you can see a lot of things on like an MRI of the brain that you may not necessarily see on, CT. All right. A lot of good questions already coming in. This is great. I'm going to answer those in a second. Let me just get through this slide and then we'll start answering a couple of these. Okay. So this right here is a CT. And, right here, we see basically, a little bit of blood there. So this patient has, intracranial hemorrhage. And, right here is an X-ray as well. Okay. So there's a question that says, how is interventional radiology different than surgery? So, on this slide, I have, what is radiology? So there's two parts of radiology. One is the diagnostic part and one is the interventional part. And we'll talk about what each of them are, and then we'll talk about how interventional radiology is different than surgery. Okay, so first we'll start with interventional radiology, right? This is a medical subspecialty that performs various minimally invasive procedures using medical image guidance such as X-ray, fluoro, CT, MRI, or ultrasound. IR performs both diagnostic and therapeutic procedures through very small incisions or body orifices. What does that mean? That's like a whole bunch of too many words, right? Basically, IR is, to kind of dumb it down, it's minimally invasive procedures using image guidance. So it's not big surgeries. Basically, what you're doing is, excuse me, you're making either a very tiny incision in a person's body, or sometimes you won't even need to necessarily make even an incision. You may just go in with a needle, depending on what the procedure is. And how we're different than any specialty is we always use image guidance. So even something as simple as accessing a vein, we trained for years basically to use an ultrasound well, so that we're able to kind of get right into the vein. If there's a mass, if we got to biopsy it, we train with ultrasound and with CT, so we can kind of get right into the mass and get a piece of it if we need to for biopsy. Okay. So the question came up, right? How is interventional radiology different than surgery? Okay. Surgery is pretty much, I guess you could say, it's kind of anything related to cutting somebody open, right? Interventional radiology is a little bit different in that it's less invasive. So patients recover, a little bit quicker. Everything is image guided in, IR. So with surgery, sometimes you do have to, depending on what's going on with the patient, sometimes you have to open up the patient and actually kind of physically go inside. With IR, it's never like that. We're basically using the body's vascular system to get to wherever we want. We could go in from the wrist or the groin, and we can get into like anywhere in the body. Once we get into either the arterial system or the venous system, we can pretty much use that. If you think about it almost like a highway, you can use it to get, off of any exit, if you will, and that's how IR is different than surgery. There are certain things that we do that surgery doesn't, and vice versa, right? So for example, if somebody has like a really bad trauma, they're in like, a motorcycle accident or like a really bad car crash, they might be bleeding from like the pelvic area. And, that's an area where it's really hard to get down into, surgically, because there's so many structures there that if you were to kind of cut someone open, you would spend so much time trying to look for where the person is bleeding from, and it would be so difficult. Whereas like IR, the way that we do it is we're looking at it under, image guidance. We're looking at it in real time. Fluoroscopy is basically X-ray in real time. So what we do is we look at it as we're doing it, right? We get into any artery, either in the wrist or in the groin, usually the femoral in the groin, or the radial in the wrist. And then what we do is, using the body's vascular system, we'll go all the way down to where the bleeding is, and then we can stop the bleeding. And that's just one example. All right. There's another question. What exactly is 3D mammo and how long does it take? I don't really want to get into too much of the nitty gritty. I can kind of answer that, a little bit later on or privately. But that's one imaging modality that you can have with mammography. It depends on, what sequences, what specifically you're looking at in terms of, mammograms. Okay. And kind of what the diagnosis is. If you're, first you start with the screening mammogram. Okay. And then basically, you have all these options, what do you like about the job? How do you think the future for radiologist medicine will look like? One thing that I love about radiology is that you're involved with pretty much everything, right? So you're involved with every part of the body, right? So if a patient comes in because they have like a really bad headache, right? They're getting a head CT, right? We're looking at the head CT. We're seeing, okay, is this normal? Is this abnormal? Right? That's diagnostic radiology, right? If a patient has chest pain, right? Probably the first thing that they're going to do in the ER is probably get a chest x-ray, right? You get a chest x-ray. Who's going to read it? Radiologist, right? You fall down on your hand, right? And, you may have a fracture, you may not. What are you going to do? You're going to get an x-ray, right? Who's going to read it? The radiologist. So we're involved with everything. Cancer, right? If, God forbid, you've got some cancer symptoms, right? What is the oncologist going to do? The oncologist is going to say, go and get a CT scan, get a CAT scan, right? Who looks at the CAT scan? The radiologist, right? So we're basically involved with almost every single aspect of medicine. I almost think about it like, you could call it like we're your favorite doctor's favorite doctor, if you will. Okay. And that's what you do as a radiologist. You know, a lot of it is interpreting the imaging, kind of telling the clinicians what is going on with this patient. All right. What does your day-to-day look like? So my day-to-day differs if, you know, and for those that are just following along, these are all questions that were posted in the chat. So I'm just kind of answering them as they come along. So my day-to-day, so if I'm on diagnostic radiology, right? What I was talking about earlier with reading images, okay? Usually what I'll do is I'll come in around, 8 o'clock in the morning, kind of, look at the list. When I say the list, right, what you guys should know about radiology is that every single department in the hospital is getting imaging of some sort, right? The ER, they're always getting x-rays, they're always getting CAT scans, right? If you are a patient in the hospital, right, chances are you're probably getting either an MRI, a CAT scan, or an x-ray, or something, right? So when we say the list, what I mean is when people get these studies done, it shows up on a list in the computer. And what we do when we come in is we look at the list and we open up a study and we look at it and we start dictating it. What that means is, right, we look at it, we have a whole checklist of things to go through, right? And we'll go through that also, on a chest x-ray, like what are you looking for, right? You have to comment on the lungs, but not just the lungs. You have to comment on the heart. You have to comment on the bones. You have to comment on the neck. You got to comment on any part of the abdomen that's, that's visible. So, we do all this, right, in just one study. And we have to basically kind of go through every study for, every patient that's getting imaging, okay? So we do that at 8 o'clock, okay? At 8 o'clock, we start looking at the list and, we do something called protocoling, right? If a patient needs a study, more often than not, the internal medicine, the ER, the, psychiatrists, the surgeons, they know what they're looking for, but they don't know exactly what study to get. So what they'll do is they'll call us and say, hey, I'm looking for appendicitis, right? I think this patient may have, an inflamed appendix. So I want to get a CT scan. But now what they don't know is, all right, with the CT scan, right, you can get it with contrast, which is a dye. You can get it without contrast. You can get it with oral contrast, where you have the patient drink contrast. Or you can get it without oral contrast. There's so many options, So how do you know which one is the right study to get? A lot of times, the only people that really know what study to get are the radiology residents and the radiologists. So what they do is they'll call us in the morning and say, hey, look, I want to get this study done. So we'll tell them, okay, this is the study that you're supposed to get. And what we'll do is we'll protocol it, or we'll tell the technicians, okay, they're looking for this and we should do this kind of study. Okay. So we do this from about 8 a.m. to 9 a.m., right? Give or take. And this kind of trickles throughout the day. And, probably from 8 to 12 or so, we're kind of like, reading imaging and everything. And yeah, so this is a typical day for a radiology resident. Just before I go on with my day, by the way, this is what it looks like, an IR suite, right? So this right here is basically, what we call the fluoroscopy machine, right? This is a real-time x-ray, right? So you can see that these guys over here, they're working here. The x-ray machine is here. And on these screens here, they're looking at exactly what they're doing. They're looking at all the vessels, all the vasculature, like everything that's going on. We can see it in front of us. Okay. So continuing with the day, right? So 8 a.m. to 9 a.m., you protocol studies, you start reading the imaging. And then, till about noon, you read your studies, depending on what rotation you're assigned to. You could be on neuro, you could be on, musculoskeletal. You could be on ultrasound, where you would read the ultrasound. You could be on like breast mammography, and we have like lots of different rotations. Okay, and then usually around 12 or 12:30, depending on the institution. Usually we have about an hour or two of lecture every day. Some places call it noon conference. We just call it lecture. It's nothing crazy or anything like that. And then usually till about, at our institution, it's about 4:30. You stick around till, you kind of, finish up your studies for the day. Sometimes you stay late till 5:30. And then you go home, right? The only times, that you would stay later is if you're on call. If you're on call, then you're going to stay till 9 p.m., right? You work 8 a.m. to 9 p.m. If you're a junior. If you're a senior, we have a little different rotations. I'm not going to really go into that too much because there's a lot of questions. Okay. So I'll let you guys digest that for a second while I answer a couple more questions. Did you always have a passion for radiology? Was there another specialty that interested you? Full disclosure, I actually thought I was going to be a surgeon first initially. Coming out of medical school, I applied to orthopedic surgery and general surgery. I ended up getting general surgery. And after probably 4 or 5 months, I was like, man, like, I like it, but I don't love it enough for me to do this for the rest of my life. So I had a difficult discussion. I had a discussion with my program director, and I was very lucky in that he was very supportive. And he said, all right, look, I'm just glad that you told me sooner rather than later. I'm going to help you out. What are you interested in possibly going into? And at that time, I thought to myself, all right, I will try for orthopedic surgery or radiology. And the reason why I actually wanted to go into radiology was because of interventional radiology. I thought it was really cool. I thought it was, kind of the future. Everything is image guided. Everything is minimally invasive, quick recovery times. Patients like it better because they can get up and walk, and they're not in the hospital for an extended period of time. So all these things to me were kind of like, all right, either I go the IR route or I go the ortho route. I think I'd be happy doing both. I ended up radiology and, in New York, where I'm from. So, I was very content. I was very happy with, how it ended up. How many patients do you see every day? That's kind of a tricky question because on certain rotations, you see a lot of patients, and on other rotations, you don't see patients. So you can kind of, depending on what kind of personality you are, you do have people who kind of like, I know it's going to be kind of weird to think about, but some people don't really want to deal with patients, and that's okay. If you want to be a radiologist who just stays in a room and just looks at imaging all day and diagnoses patients like that, that's totally fine. But there are a lot of rotations where you're going to see a lot of patients. So for example, when you're on mammo, which is women's imaging, you're definitely dealing with lots of patients. When you're on interventional radiology, IR, you're talking with patients before the procedure, after the procedure, you're getting consent, because you have to explain the procedure as well. You're doing the procedure on the patient. So that's pretty heavy on that. When you're on ultrasound, right, we do ultrasound. So in that, you're interacting with a lot of people as well, with a lot of patients as well. So, there's no straightforward answer as to how many patients you see every day, but, we see a lot of patients depending on what rotation we're on, okay? There's another question. What is the most challenging part of being a radiologist? That's the first question. Probably the amount of knowledge that we have to have. You really have to know pretty much every system in the body. We've got to know bones, we've got to know abdominal imaging, we even have to know cardiac imaging. Like we get tested on cardiac MRI and cardiac CT and even nuclear studies for cardiac. So, we really have to know everything. So it's definitely a little daunting at first because, you really have to have this fund of knowledge that's just kind of like the entire body, So I would say that's probably the most challenging part, but it's also kind of fun in the sense where it's like, okay, this is a little bit of a challenge. Let me see if I can learn all this. Let me see if I can get all this, How often do you have to do an MR scan? A lot of this depends on, everything is all about the patient. And you guys should remember this no matter what field you go into, whether you go into radiology or something else. Everything is about the patient. So when you're making decisions, you have to think about, all right, what is best for the patient, right? For example, right, if there is somebody who is having seizures, right, and you get a CAT scan and the CAT scan looks normal and you really want to, you're concerned that there might be a mass in the brain or something, there may be a tumor, something like that. So that would be an indication to get an MRI of the brain, right? Or so, for example, right, let's say, you get an x-ray, you get a CT of, let's say, the foot. And there's a patient who's diabetic and they may have a foot infection called, osteomyelitis. It's basically a fancy way of saying that the infection has reached the bone, right? That's a very serious infection. Sometimes, for that, you would potentially need an amputation or at the very least long-term antibiotics, right? So for that, sometimes you want to get an MRI for confirmation because you don't want to imagine you're the patient, right? And there's a question of whether it's really an infection or not. You don't want somebody to go in there and start amputating your foot without like really definitively knowing if it needs it, right? So like, MR is really good for certain things. It's very good at focused, imaging, right? It's not good for kind of wide areas. So for example, if you're getting, if you need to get, imaging from here to here, from your chest down to, your pelvis, that's too big for MRI. And I'm not going to go into the physics of this, but, the resolution of the MRI is really, really good. But the drawback of MRI is you can't really image a wide area at one time. Whereas CT, you can kind of go through the whole thing. Okay. MRI also does not have radiation. It works on magnets. But yeah, so I'm not going to, I already went probably way too far into that. Let me go through this a little bit, then I'm going to answer a few more questions. Okay. So we talked, typically for a radiology resident, meaning diagnostic radiology resident, right? Okay. So I'm going to answer a few questions, but I do want to talk a little bit about the x-ray. Okay, because this is the very basics. I want to give you a little bit of exposure to radiology and kind of like what the very basics are. Okay, so when we're looking at this chest x-ray, okay, right, the first thing you got to remember is you got to imagine as if you are looking at the patient, right? So see where it says L over here? That's the left side of the patient and the other side is the right. So you have to look at it as if the patient is in front of you right here and you're looking at the patient. Okay, so here's the right side, here's the left side. There are multiple parts of the chest x-ray, right? We have the lungs, which are in black. Okay. This is the right lung. This is the left lung. We have the heart here. Okay. We can kind of see that. All right. We've got the ribs coming across here. The ones that are horizontal are the posterior ribs, meaning the ribs coming behind us. Okay. And then if you look closely, you can kind of make out, these curved structures, which are basically the anterior ribs, which is kind of like the front. Okay. We've got the spine here. We've got the clavicles. We've got this right here, which is, the scapula. Okay. Now, as a radiologist, you're responsible for everything. So let's say they being the ER, right? They're worried about, okay, this patient has difficulty breathing. Maybe this patient has a pneumonia. Let's get a chest x-ray. Okay. So they get a chest x-ray and incidentally, you see that, oh, this patient has maybe a clavicle fracture or something. We as radiologists, we're responsible for every single thing on the screen. So it's our job to convey to, the ER staff, hey, this patient, I know you were looking for pneumonia, but this patient actually has a clavicle fracture. So, just to let you know about that. Okay. So just looking at this, right? So, all right, just a little bit of anatomy. Okay. We've got the manubrium. Okay. We've got the superior vena cava right here. That's the main vein that brings blood back to the heart. Okay. We've got the right atrium. That's where the blood initially goes into. Okay. If you continue along here, your right ventricle kind of comes along this way. Okay. And then your left ventricle is kind of the left edge right here. Okay. And within the right lung, you have these fissures, right? Horizontal fissure, oblique fissure. Okay. And then in the left lung, you only have one fissure, right? The oblique fissure. Okay. Anything that's in black completely is going to be air. Okay. Here's your gastric bubble, which basically means your stomach. Okay. All right. So I'm going to leave this on the screen for a minute and then, I'm going to answer some questions. Okay. Is the constant exposure of X-ray imaging dangerous for you because of radiation? What attracted you to this job? Okay. So we don't get exposed to X-rays, but I think what you're referring to is kind of the fluoroscopy, which is what we do in IR. What we do to protect ourselves, and that's a really good question because, yeah, it is radiation and, yeah, it could be dangerous. what we do is we wear lead, and the lead is basically protective. So wherever we're covered with lead, basically kind of the X-ray beams, they either the lead absorbs it or it's kind of bounced off. The main thing is, we don't absorb, all that radiation that's, basically kind of coming from the fluoroscopy. Okay, so we do take the precautions. I actually have, I've got a lead headband that I basically kind of wear to kind of protect my head. They give us lead goggles, so we'll wear those lead goggles kind of, and you can actually, if we go back here, just see if I can go back for a second. Yeah, so you look at these guys over here, they're wearing goggles, and you look underneath their gowns, they've got these thyroid lead protectors, and underneath their gowns, they're also wearing lead protection. It's kind of like a heavy vest, and then there's like kind of a lower part as well. All right, let's see, what else? What attracted you to this job? Like I was saying, part of diagnostic radiology and part of interventional radiology. Diagnostic radiology is really cool because it involves every part of the body. Interventional radiology is really cool because you do all of diagnostic radiology and you have the ability to do these minimally invasive procedures. All right. I was reading online that the job outlook for radiology is increasing. Do you see a lot of job openings and availability for work? Yeah, you know what? Honestly, the thing is, if you become any kind of physician, any kind of doctor, the jobs will be there. It's just a matter of what you want, right? So for example, if you want to be close to like a big city, if you want to be in New York, if you want to be in, Chicago, LA, a lot of these big cities, you're going to get paid a little bit less. And, if you go more to rural areas, you'll probably get paid a little bit more. And there'll probably be a little bit more job, opportunities out there. So it all depends on what you want. If you're comfortable with kind of taking a little bit of lower salary and maybe having, a little bit more competition with your job and you're fine with being in a big city, that's fine, But the beauty of, radiology in particular is that you have a lot of freedom. You have a lot of, you can really go anywhere in the country. You could even work from home if you wanted, because a lot of these things in terms of diagnostic radiology, you can read these x-rays from home. You can read these MRIs from home. You can read these CT scans from home. Okay. Yeah, so there's definitely availability for work. How many cases do you usually see in a day and how long do you typically spend with your patients? So that varies, right? If you're on diagnostic radiology where you're reading, imaging studies, obviously you're gonna be seeing like a lot because as x-rays are done, as CTs are done, as MRs are done, and they do them all the time. They're just coming onto your screen and you have to grab them. So it could be anywhere from 60, 70 studies a day when you're on diagnostic radiology. And when you're on interventional radiology, usually, depending on how busy it is, we'll do anywhere between like 4 to like, I think the most I did in one day was like 9 cases, 9 procedures. And, so it really just depends on the day, depends on, kind of what's going on in the hospital, how many outpatients you have. All right. Did I shadow any radiologists during undergrad? No, actually, to be 100% honest, I didn't even know radiology in college, in college and before I went to medical school. And honestly, even in medical school, I never did a radiology rotation. I did not think that I was going to go into radiology, but when I learned about interventional radiology, I was like, man, like this is cool. Like this is kind of exactly what I want to do, where I can do all the procedures. I can be involved with clinical judgment and decision making, and everything is image guided for the future. And you know what? A little bit of it is also lifestyle. I wanted to be able to do things outside of the hospital, and I got to be 100% honest. Doing general surgery, it's very difficult to have a life outside the hospital. So these are all factors as to why I decided, I wanted to do interventional radiology. All right. All right. How does a radiologist minimize radiation exposure? Although y'all are exposed very often, this must be somebody from the South. I see with the y'all. Yeah, like I was saying earlier, basically, we wear lead to protect ourselves. We wear usually a vest on top, and it's a skirt on the bottom, basically kind of protecting, your groin area and everything. And then we wear a thyroid shield as well to protect us. All right. How has COVID-19 changed your daily routine and the patients you see? So that's a really good question. I'm going to answer that in a little bit. Okay. I want to go on to the case. We'll do the case, and then in the middle, we'll do some questions. Okay. So, all right. So case presentation. Okay. We've got a 72-year-old woman who is admitted to the hospital with acute respiratory failure. She's got a fever and she's got dyspnea. Okay. She's tachypnic, meaning she's having, increased amount of breathing per minute. Normal is usually 12 to 20 breaths per minute. She's breathing at a rate of 30 breaths per minute with lymphopenia, meaning an increased amount of lymphocytes or white blood cells, and low oxygen saturation of about 85%. To give you guys an idea, in case nobody knows, normal is usually, if you're kind of like, if you don't have COPD or anything like that, in the, usually high 90s, right? So she's satting kind of low. So I want to ask everybody, okay, a little bit of interaction, right? What do you guys think so far, right? Put it down, in the, in the comments, in the chat box. What do you guys think is going on with this patient so far? I'll give you guys a minute to type. And while we're waiting for some answers, I'll basically kind of answer like a question or two. How has COVID-19 changed your daily routine and the patients you see? Well, honestly, in New York, when it was really bad, we were actually going to the floors and taking care of, COVID patients. We were taking care of COVID-19 patients and helping out because we were just so overrun. Once we got back to radiology, the patient, the only thing that's really changed at this point, we're kind of back to normal in the sense of, we're doing all the procedures in IR. Our volume is pretty high for diagnostic radiology as well. The only thing is now we try to really protect ourselves. We wear 2 masks, wear an N95 mask, and just kind of make sure that you're protected because, COVID-19 is real, believe me. I've done CPR on a patient who had COVID-19 and, unfortunately he died. But I've seen people die from COVID-19. So, it's something that we take very seriously. But in terms of the routine, it's still a pretty similar routine. Hardest part of being a radiologist, again, like I said, just really having to know kind of like everything and put together, it's almost like a puzzle, putting your the pieces of the puzzle together to figure out exactly what's going on with the patient. How did you choose radiology as a specialty? Did you consider any other specialties? I answered this before as well. I was really attracted to IR, interventional radiology, which is kind of the procedural part of radiology. And, I did consider general surgery and orthopedic surgery before, going into IR. All right. Okay. So let me see. Okay. Somebody said COVID. Does she have COVID? She can't breathe. So maybe there's an issue with the respiratory tract. All right, good. I like this thought process. I like where people are, thinking with this. That's good. That something is going on with the respiratory system. Okay. COVID is a good guess, right? Thoughts, differential. So by the way, if anybody who's not a resident or anything, when you see the word differential diagnosis, basically what that means is, the attending or the resident or, the fellow is asking you, what do you think it could possibly be, right? Don't give me one answer, but give me maybe a couple of things that it could potentially be based on, what the symptoms are and everything. Okay. Some sort of viral infection, COVID. Good. A lot of people are thinking that. Okay. So now I'm going to give you a little bit more of the story. Okay. The patient presented to the emergency department 2 days earlier. She had a fever, a dry cough, odynophagia, which is difficulty swallowing, and general malaise, meaning just generally not feeling good. She was discharged from the hospital because she didn't present with any kind of alarm criteria at that time. Okay. Now I'm going to ask, does this change any of your, differential diagnoses? I'll give you guys a second if anybody wants to type it in. Okay. And then this time I'll take a moment to just answer another question. Okay, hi, Dr. Baig. Thank you for this opportunity. You're very welcome. Okay, I was wondering how much patient interaction do you typically have? You know, like I said, depending on the rotation, you know, you can have a lot of patient interaction, or you can have not so much. Okay, so the ones that are heavy with patient interaction, IR, you're always dealing with patients. Mammo, you're always dealing with, you know, most of the time women, you know, with mammograms, with ultrasound and everything. If you're on ultrasound, you're dealing with, you know, you're treating patients. You're doing the ultrasound on patients, looking at them. You may have to go and do the scan again if you want to look at something in particular. There's another part of radiology called GIGU, where basically you're doing fluoroscopy procedures where you're having patients, you know, either drink contrast and looking at it go down, like speech and swallow, you know, studies. So with that, you're dealing with patients as well. So when you're in those aspects of radiology, you're dealing with patients a lot. When you're on certain other aspects, for example, you know, if you're just on ER, right? You're not actually going into the ER necessarily and seeing the patients, but what you're doing is as the ER does their X-rays, CTs, and, you know, if necessary, MRIs, you're looking at the images, you're calling the ER docs and saying, this is what I see, this is what it looks like, you know, and maybe you talk to the ER docs and say, hey, you know, I think it's this, what's going on with the patient? Can you give me a little bit more of the history, or what was your physical exam like? And I would do that all the time. And it's really important to, you know, kind of have both. Okay. Okay, so it looks like everybody's still thinking kind of along the same lines. Okay. So now, all right, so let's go a little bit through the imaging, right? So remember, this is normal, okay? I want you guys to keep this in mind. This is a normal chest x-ray, right? So look at it. It's nice. It's a lot of black, which means a lot of air. You know, these like wispy, linear, excuse me, whitish things, those are normal. That's normal vasculature. Remember, we have blood everywhere, right? So we have blood going to the lungs. Because remember, blood is what? Blood carries oxygen. Blood carries nutrients. Blood is basically kind of your highway system of the body, right? It brings things here and there. Okay, without blood, your organs will die. Okay, so just keep this image in mind. Okay, look at how everything is, and we're gonna go here. Okay, so what do you guys see? Real quick, I wanna see some. You know, give me a few things that you see in the chat box. Okay, here are the lungs. Okay, here's the heart. Okay, this is kind of the, you know, you have your breathing tube, the trachea. Okay, so I want to get some ideas as to what do you think it is? Is it normal? Is it abnormal? Okay, someone said cancer. One lung is getting more oxygen than the other. Okay, good. Pharyngitis. Okay. I don't want any specific diagnoses right now. Just what do you see? What do you see? Okay, ARDS, good thought, very good thought. Okay. ARDS, for those of you who don't know, means acute respiratory distress syndrome. Okay. The middle part seems larger. Okay, good. All right, so good. As the you know, comments come in, we'll go through it a little bit, right? Excuse me. So remember, right? All this is lung. Okay, this is all supposed to be black. This is not black, right? You see, there's this whitish stuff here. There's whitish stuff here. There's kind of like these hazy kind of opacities. Right. Somebody said lungs look cloudier. Okay, yeah. So it's this hazy kind of opacification going on, right? So, and you could say that it's kind of peripherally located, right? It's kind of located a little bit towards the outside, right? So this is what it is at admission. All right. So now what we're gonna do is we're gonna look at it 4 hours later, like that thing on SpongeBob, right? 4 hours later, right? So all right. So now we're looking back at the lungs, right? And this part, okay, this part looks not too bad, right? Because it's black. Black is air, right? but everything over here is like pretty hazy, right? And everything down here is pretty hazy. We can kind of see these almost like cloud-like opacifications. So when we see that, what we call, the terminology that we use in radiology is consolidation. And okay, try to wrap up by 8:40. Okay, all right, no problem. So I'm gonna try to go a little bit quicker, okay? So when we see these things, consolidation, basically that means that there's something within the lungs. There's something within the alveoli, which is kind of like the the deepest part of the lung. Okay, it could be water, could be pus if it's bacteria, could be blood, right? So on X-ray, you can't really differentiate between the two, not the two, the many, right? So all we say is that there's some sort of consolidation. Okay, this looks to me, just because I've seen a bunch, this looks like it could be kind of an atypical pneumonia. And what does that mean? Atypical pneumonia includes viral pneumonia, it could include COVID, it can include multifocal pneumonia as well. Okay, let's keep on going because we're running out of time. Okay, now we see that there's kind of these multiple opacities kind of throughout the lungs bilaterally on both sides. Okay. And it just seems to be getting worse and worse and worse. And one thing I do want to bring your attention to is if you look at admission, right, we see the breathing, our normal breathing tube, right, the trachea there. When we look at it 4 hours later, there's something there. There's something in the trachea, right? And that is an endotracheal tube, right? That is not a good sign. When a person needs a tube to be put into their trachea to breathe, to get enough oxygen, that's not a good sign. That means that this patient's not doing well. They're headed for trouble. Okay. And we still see that there. And we see, even 48 hours later, we still see all these consolidations. And actually we can see that the breathing tube is kind of going down almost to the right. If there's a situation like this, we would actually call the team and we'd say, hey, the endotracheal tube looks like it's going into the right main stem bronchus. You should probably kind of pull back a little bit. Why would you pull back? If your breathing tube is only going to one lung, that lung is going to get so much air, but the other lung is not going to get any air at all. And you don't want that. Okay. So, all right. So 72 hours later, it's kind of getting worse. It looks like you've got maybe some fluid there. You've got consolidations. So just to summarize, right? At admission, there were these bilateral alveolar consolidations with peripheral distribution, basically a fancy way of saying that there were these whitish opacities at the outside of the lungs. Okay. 4 hours later, it looked worse, got worse in the lower parts of the lungs. Okay. There was an endotracheal tube, there was a central venous line. 24 hours later, it was bilateral on both sides. 48 hours later, it looked even worse. 72 hours later, ARDS, right? Acute respiratory distress syndrome, right? And then 24 hours after the last X-ray, the patient actually passed away. So what did the patient have? The patient had COVID, okay? For those of you guys that guessed that it was COVID initially, you guys were correct. The patient had COVID-19, and that's kind of typical, right? These findings are pretty typical of a patient with COVID-19. Okay, especially this peripheral distribution, right? Peripheral opacification. That has become kind of classic, if you will. Okay, but very early on, right? You may not necessarily see much on X-ray. Okay, remember I was saying there's different imaging modalities, right? X-ray uses radiation, but look at it over here, right? This looks totally normal. There's black lung right there. You would look at this and you would say no consolidation, But when you get the CT, you could see that, right? You see that all this here, this black stuff, that's normal lung. This is not normal, okay? All right, so we got 9 minutes, okay? So let me just finish up really right here, and then I'm going to try to get through all your questions as much as possible, okay? Right, so we mentioned this already, right? We talked about this kind of peripheral consolidation, okay? I'm not going to go through the other case, okay? So now, all right, we'll get to the questions, and I'll just leave this on the screen for now, okay, in case people just want to look at the chest X-ray. Okay, So what are the chances that someone misreads an MRI scan or any type of scan in general? It happens. The thing is, right, we ultimately as humans and as radiologists, and as any kind of doctor, you're going to try your best, and you're going to kind of put your best foot forward and really try to get it right. Every so often, once in a while, you may miss something, and you try your best to make sure that it doesn't happen. If it happens, if it's caught, you immediately let the patient know. That's the ethical thing, and you basically immediately let the team know, meaning any person who's involved with the care of the patients that would need to know, you would let them know. For the most part, though, you have to realize that we go through 4 years of residency and then at least 1 year of fellowship, sometimes 2 years of fellowship. So we're talking 5 to 6 years of training. And then after that, we're still we're still having to do continual education, right? Continuing medical education. So we're constantly having to learn and, kind of renew what we know, refresh what we know, and learn new things as well. All right. Why did you want to pursue a career in radiology? Again, I really like the interventional aspect. I thought it was really cool that, you would have the ability to look at imaging, diagnose patients on, based on imaging and clinical picture, and then also have the ability to do something about it. You can kind of intervene, you can do procedures, so I really like that aspect. So that's really why I wanted to do radiology. Do you work with physician's assistants? At my hospital, we don't really, not in our department, there are PAs, but I know in lots of hospitals, there are lots of physician's assistants. We work a lot with nurses, but PAs definitely are, they play a crucial role especially for IR. Has there ever been an image result that was complicated for you to analyze? If so, how did you figure out and overcome this challenge? Yeah, of course, there's always going to be certain challenges, and you try to face them as best as you can. But, one thing about radiology is that we're not afraid and we're not shy to ask each other for help. And that's one of the great things also about radiology is that, we recognize that there's so much to learn in the body, and you can't be arrogant. Like, you can't just think, oh, I know everything. Because medicine, no matter what you do, it's going to humble you. Just when you think you know everything, there's going to be something new that comes up. There's going to be something that you didn't know about that you're going to learn, and that's okay. You always, if you're not sure about something, call somebody up, somebody that has more experience than you. There's no shame in that. It's better for the patient. Remember, the patient is always number one, right? It's better for the patient for you to take those extra 5 minutes, call somebody that has a little bit more experience, say, hey, do you mind taking a look at this? I think it's this, but, I'd appreciate, a second pair of eyes. I know you've looked at a few more images than I have, and there's nothing wrong with that, So that's how you would kind of overcome the challenge. And then you can also look things up. We have plenty of books. We have lots of resources at our disposal. So yeah. All right. Involved with proton therapy for cancers, radiology. We do lots of different treatments, for, different kinds of cancers. So proton therapy, I'm not entirely sure exactly what that's referring to. We do a lot of, chemoembolization. We'll do ablations and things like that. Yeah. So when you say you read imaging studies, does that mean just reading scans like a diagnostic radiologist, or do you do more procedural cases like IR cases? I do both, because basically at the end of my fellowship and training, I'm going to be certified in both interventional and diagnostic radiology. So when I say reading the imaging studies, specifically reading, I'm referring to diagnostic radiologists when we actually dictate. But at the same time, the IR guys, excuse me, we're all able to read the images as well. We can dictate, and we can look at the images without actually dictating and be able to, see what's going on. And I think this is the last question. So that's good, because we're almost out of time. Where'd it go? All right. What do you think about AI in the field of radiology? That's a really good question. That's a hot topic, right? AI is a really, really useful tool. And, it's ultimately going to be involved with probably pretty much every aspect of life, I would imagine, at some point. The issue with AI is it's really good if it's used as an adjunct. The tricky part is, let's say, for example, if I'm a patient, right? I understand that AI is, you can teach it to do kind of anything. It can learn, after looking at a whole bunch of scans, it can learn what's normal, what's not normal, and everything. If I was a patient at the same time, I would still want, a radiologist kind of overlooking it. I wouldn't want it to just be a computer software, just reading my X-ray, CT, MRI, whatever it is. So I think that the way that it's going to be utilized is, I think it's going to be used to kind of prioritize what is a study that needs to be looked at immediately. Because there are certain studies that are normal that you look at them and it's like, okay, that's fine. Like I can get to that later. But there are certain studies that are acute. For example, if somebody has a head bleed, right? That's something that you need to look at right away. So AI would be really good at kind of stratifying, okay, this is an emergency. Look at this first, right? This is not really an emergency. You can look at this later. Things like a collapsed lung, like a pneumothorax, right? Or an aortic injury, right? The aorta, as we all know, basically it's the main blood vessel coming out from your heart to the rest of the body. If you have an injury there, that could potentially kill you. So that's where I see AI going right now. The other aspect is from a medical legal perspective, for better or for worse, the lawyers of this country, they're always going to want to hold somebody accountable, right? So if it's just a software, I'm not sure how that's going to work. Right now, if it's a radiologist, they can easily call you to court and say, well, what do you see on this study? Can you explain your thought process behind this? But, if it's a software that's only doing it and there's no oversight, I'm not sure how that would work. All right. So that's pretty much it. If you have any questions, please feel free to message me on Instagram. I am on TikTok. I'm not as active on TikTok, to be 100% honest. I had to actually delete. I love TikTok, by the way. But I had to actually delete it for a little bit because I have exams coming up, so I got to kind of focus a little bit. So I got rid of TikTok. I still have the Instagram. I don't go on it as much as I used to go on TikTok. But please feel free to message me. It's Asad Baig, MD, ASAD, BAIG, MD. On that, I'm pretty quick at responding. You could email me as well if you have something a lot longer to say. I take a little bit longer to get back to you over email, but I will get back to you. But if you have any questions, or if you want to learn a little bit more about radiology in terms of diagnostic or interventional or the pathway, or just medicine in general, if you're a pre-med, you're not sure what to do, or kind of like how to navigate these waters, just send me a DM and we'll talk a little bit. Okay. I hope this was helpful. And I'm going to turn it back over to the the host, and yeah.
All right. Thank you so much for joining us today. It was a true pleasure to get a little bit of an insight of everything that goes on in radiology. I'm so sorry to cut it so short, but I think everyone here gained a little bit of an insight of what you do, and I think we all are a little bit more interested in radiology than we were before the session. So thank you so much.
All right, guys. Take care.
So to the rest of you guys, the Google form has been posted on the live chat, and try to fill out that form before 9 o'clock in order to gain your shadowing hours. And we have one more session lined up after this. So that will begin in about 5 minutes. So